The dangers of a stealthy lung invader, unpacking a severe case of community-acquired Pseudomonas aeruginosa pneumonia.
Imagine facing a respiratory infection that progresses rapidly, defying standard treatments and potentially leading to fatal outcomes. That's the terrifying reality for patients grappling with community-acquired Pseudomonas aeruginosa pneumonia, often abbreviated as PSAP, a condition that's becoming increasingly common and challenging. In this piece, we'll dive deep into a real-life case study, exploring the science behind the bacteria, the telltale signs on imaging, and cutting-edge ways to detect and treat it.
But here's where it gets controversial. Are we underestimating the role of everyday antibiotic misuse in fueling these superbugs?
And this is the part most people miss: how early detection through advanced imaging could save lives, yet many healthcare systems still lag behind. Let's break it all down step by step, making complex medical concepts accessible, even for beginners, so you can follow along without feeling overwhelmed.
Introduction.
The rise of multidrug-resistant (MDR) and extensively drug-resistant (XDR) strains of Pseudomonas aeruginosa, largely fueled by the overuse of antibiotics, has created major hurdles for doctors treating infections. This bacterium, often lurking in hospitals but increasingly found in community settings, can cause pneumonia that worsens quickly and has alarmingly high death rates. Our discussion pulls together the latest findings from research both here in China and internationally, zooming in on three essential elements: how P. aeruginosa develops resistance to drugs, the distinctive patterns visible on chest scans, and modern techniques for identifying the pathogen. We'll explore how prompt identification and precise treatments can make a life-saving difference for this aggressive lung ailment, offering a roadmap for clinicians and patients alike.
Case report.
Picture this: a 64-year-old man with a long-standing battle against chronic obstructive pulmonary disease, COPD, who hasn't been sticking to his prescribed inhaled medications like inhaled corticosteroids combined with long-acting beta-agonists, ICS-LABA. His COPD severity, measured by the Modified Medical Research Council (MMRC) dyspnea scale, was rated at 0, meaning he had minimal breathlessness in daily activities, yet underlying issues persisted. On September 5, 2024, he walked into our emergency fever clinic complaining of a productive cough with yellowish mucus, spiking fevers hitting 39.0 degrees Celsius, and a sudden onset of symptoms that had lingered for 5 days. These warning signs escalated into breathing difficulties, chest tightness, and exhaustion so severe he could barely move, leading doctors to assess his risk using the CURB-65 tool from the American Thoracic Society. This tool evaluates factors like confusion, high blood urea, over 7 millimoles per liter, rapid breathing, 30 breaths per minute or more, low blood pressure, under 90/60ths mmHg, and age over 65, yielding a score of 2, indicating a moderate risk with about a 9.2% chance of dying within 30 days.
He needed either a short hospital stay or close outpatient monitoring.
Fortunately, he had no other health issues like high blood pressure, diabetes, or heart disease, and no known allergies to medications. A chest CT scan that day showed infection spots in the upper and lower parts of his right lung, see Figure 1a, so he was admitted for more tests and care.
Figure 1, changes in imaging over time. A. On September 5, the chest CT scan revealed solid areas of infection in the right lung's upper and lower lobes.
B. By September 9, a follow-up CT showed a thick-walled empty space in the right lung, with the infection worsening significantly from the initial scan. C. On September 17, the CT indicated an empty space with fluid and air in the right lung, suggesting an abscess was forming, plus a small buildup of fluid around the lung. D. By October 1, imaging displayed ongoing empty spaces in the right upper lobe with inflammation and some lung tissue damage, along with balloon-like air pockets in the left lung from emphysema. E. On November 30, the chest CT showed lasting changes in the right lung's empty spaces, but with much less inflammation and fluid around the lung compared to October. Despite stable blood pressure at 104/74 mmHg, he struggled with dangerously low oxygen levels, SpO2 at 84% on 2 liters of nasal oxygen per minute, a racing heart at 129 beats per minute, and quick breathing at 30 breaths per minute. His temperature had dropped to 37.2 degrees Celsius, but he was restless and agitated. Lung sounds included coarse noises and crackling on both sides, his heart beat regularly without extra sounds, and his abdomen felt soft with no tenderness or enlarged organs. His legs showed no swelling from fluid buildup. Initial blood tests revealed high white blood cell counts, 18.95 times 10 to the power of 9 divided by L, mostly neutrophils at 17.87 times 10 to the power of 9 divided by L, and low lymphocytes, 0.5 times 10 to the power of 9 divided by L, plus sky-high inflammation markers like C-reactive protein, 213.8 mg per liter,
and procalcitonin, 41.3 nanograms per milliliter, as detailed in Table 1.
Blood gas analysis indicated a mixed issue. His body was trying to compensate for respiratory alkalosis, pH 7.45, oxygen pressure 74.7 mm of mercury, carbon dioxide pressure 26.5 mm of mercury, but lactic acidosis was present, lactate 4.0 millimoles per liter,
base excess minus 5.7 millimoles per liter.
Other imbalances included low albumin, 29.00 G/L, from widespread inflammation, low sodium, 130.32 millimoles per liter, and low chloride, 94.52 millimoles per liter.
Kidneys were mildly affected, creatinine 96.00 moles/L, blood urea nitrogen 9.55 millimoles per liter, and heart tests showed elevated NT-proBNP, 2916.30 pg/ml, with an irregular heartbeat on ECG. He was diagnosed with a COPD flare-up complicated by severe community-acquired pneumonia and type I respiratory failure, with signs of bacterial sepsis, procalcitonin over 20 nanograms per milliliter, and multi-organ stress. The low oxygen was causing heart rhythm issues, and inflammation was depleting his protein levels, all demanding constant watch. Table 1, shifts in inflammation markers over time. Treatment kicked off with ceftazidime/avibactam, 3.0 g every 8 hours, plus medications to open airways and loosen mucus. A sputum sample on September 8 grew P. aeruginosa sensitive to ceftazidime/avibactam, imipenem, cefotaxime/avibactam, ciprofloxacin, and gentamicin, but resistant to ampicillin, ampicillin/sulbactam, cefotetin, ceftriaxone, cefazolin, meropenem, and cotrimoxazole. No fungi or bacteria showed up in blood cultures. Still, his condition worsened, fevers returned to 39.0 degrees Celsius, breathing got harder, he coughed up blood, and his vitals dipped, blood pressure 88/57 mm of mercury, breathing rate 31 breaths/min. Oxygen needs rose, with PaO2/VO2 at 137.5 mm of mercury on 6 liters per minute mask oxygen. Repeat blood tests on September 8 showed ongoing high white cells, 15.51 times 10 to the power of 9 divided by L, neutrophils 14.29 times 10 to the power of 9 divided by L, lymphocytes 0.6 times 10 to the power of 9 divided by L, and inflammation, CRP 213.8 mg per liter, PCD 23.31 nanograms per milliliter, IL-6 497.37 pg/ml, per Table 1. Blood gases confirmed respiratory alkalosis, pH 7.47, PaO2 60.5 mm of mercury, PaCO2 27.7 mm of mercury, with lingering lactic acidosis, lactate 2.10 millimoles per liter, B-5.7 millimoles per liter. A September 9 CT scan highlighted growing empty spaces in the right lung, Figure 1b, so antibiotics switched to meropenem, 1.0 g every 8 hours for broader coverage, and esmolol, 0.2 g every 8 hours to slow his heart rate. A bronchoscopic wash in advanced sequencing, MNGIS, confirmed P. aeruginosa, 52,090 sequences, carrying OXA resistance genes and toxins like XOU and Lassa. With ongoing fevers, 38.3 degrees Celsius, and new resistance to ertapenem/imipenem, treatment adjusted to cefoperazone/sulbactam, 3.0 g every 8 hours, plus azithromycin, 0.5 g daily, on September 14. By September 17, he stabilized, fever gone, breathing easier, and markers dropping, WBC 15.96 times 10 to the power of 9 divided by L, CRP 39.88 mg per liter, as in Table 1. CT scans tracked the disease's evolution, from solid infections on September 5, Figure 1a, to growing voids on September 9, Figure 1b, abscess hints on September 17, Figure 1c, and persistent voids with damage by October 2, Figure 1d, resolving somewhat by November 30, Figure 1e. Control came via cefoperazone/sulbactam, ciprofloxacin, and inhaled aminoglycosides. Inflammation levels plummeted compared to admission, Table 1, showing the infection was under control. He left the hospital on October 8, continuing oral ciprofloxacin, 0.1 g daily, and tiotropium inhalers. Discussion. Studies show P. aeruginosa is rare in typical community-acquired pneumonia, infecting just 0.9 to 1.9% of cases in the US and 1% in China, but it spikes to 1.8%